we are going to go through the different parts of clinical documentation today. I'm going to start with a brief overview of all the different types of documentation that are going to be required. And then as we go, we're going to get into more detail about each different thing. So I'm going to start by talking about clinical assessments. Clinical assessments are done at the beginning of services. And then if a client is in services for long enough, they'll need to be done annually. The point of the clinical assessment is to capture the big picture of the client, including their history, their current needs, and then the goals that they're going to need or want to work on throughout services. The annual or initial assessment should justify the client's need for services, and it should tie into their ISP, which will have their treatment goals for services on it. Their ISP, so this is their service plan, their treatment plan, should be person-centered, and it should be collaborative. So we don't make treatment plans for clients, we make treatment plans with clients. The goals for the client that end up on the treatment plan should tie into the information that was reported in the assessment. The objectives that we put on treatment plans have to be measurable and obtainable, and they should be based on what the client is reporting they want or need to work on. We'll get into more of that as we go on. So if you're like, what is she talking about? We'll learn. Progress notes. Progress notes are done session by session. Every time you see a client, you should be writing a note for that contact. The progress note is going to provide an overview of what you're doing each time you're meeting with the client. And ultimately, progress notes as you go on should be tracking the client's progress towards their treatment goals. So the assessment, the treatment plan, and the goal and the progress notes should all be tying together, starting with the assessment that identifies what's been going on, what's not going well, the treatment plan that says, well, here's what we'll work on because of those things that are not going well, and then the progress note saying, here's the work we're actually doing, here's the progress that's being made, or the progress that is not being made sometimes. And then treatment plan reviews, we do ISP reviews every 90 days or every 6 sessions, whichever comes first. The treatment plan review is going to give a more in-depth look at the progress or lack of progress than the progress notes have been giving. So progress notes are brief and sometimes can be a little bit vague, but when we do a treatment plan review, we look at each objective that we had on the treatment plan, and we talk about what has happened with this objective so far. What progress has been made? How is the client still struggling? And then it also serves as an opportunity to reevaluate the goals and objectives that we initially made or last updated. Sometimes we may want to look at the goals and change some goals or add new goals. So essentially, the treatment plan reviews are going to be tracking the client's journey towards meeting their goals, which means ultimately their journey towards discharge.
Okay, so do I have to do an ISP review if I want to discontinue a goal? Like I have a few transfers. From one of your previous clinicians, Michelle, and the client and the parent are like, And so do I have to do a formal ISP review, or can I just change it in that session with them?
Yes, ISP summary reviews do have to be done in order to make changes to the treatment plan. This training is not specifically about how we do things like that incredible. It's more of just a clinical documentation training overall. But that is something you should talk further to your manager, supervisor about, because those changes do have to be made in a summary review service.
Okay, thank you.
Yeah. And the reason for that, just briefly, is that when we make any changes to a client's treatment plan, the client has to be able to sign off on those changes, which is why we have to do an actual service so that their signature can be put there. So the golden thread is a concept that is thrown out a lot when we talk about clinical documentation. The idea is that the assessment, the treatment plan, the progress notes should all be connected. So there's this idea that there's this golden thread that should weave through all of these pieces of documentation. So like I said, the assessment is serving as the foundation for all services. Whether a client goes into case management, outpatient counseling, medication management, mental health skill building, that is assessment that was initially done should be identifying why the client needs that service and what needs to happen throughout the services. So the assessment is going to gather the information that we need to build that treatment plan. Likewise, the treatment plan should be reflecting the needs identified on the assessment. In the assessment, if we are identifying depressive symptoms and mood dysregulation, issues with socializing, the treatment plan should be addressing those needs. Vice versa, if the treatment plan is saying the client is going to work on sleep regulation and coping skills and trauma processing, the assessment should have identified that there are issues with trauma processing and sleep regulation and coping skills. Does that make sense? And then the golden thread ties all the way through the progress notes and the treatment plan reviews, because our progress notes should be reflecting that progress or lack of progress on those treatment goals that were identified using the needs identified in the assessment. So the treatment notes, the progress notes, are ultimately the justification that is going to go into the ISP summary review. So when we do a summary review and we say, Susie has not progressed towards this identified objective yet, our notes should be reflecting what we were trying to do or what we did so far towards that objective. Or if we say Susie has made significant progress towards this goal, our progress notes are going to show the interventions, the actual work we did to get them to that point, which is why they all tie together. So if I'm working on mindfulness and grounding techniques in a session, that should clearly tie to one of the goals on the treatment plan. And if that has nothing to do with any of our treatment goals, then we either need to question why we're working on mindfulness techniques or why we're missing something on the treatment plan.
Quick question.
Yes, ma'am.
So I realized that all of my clients have very generic treatment plans, in a sense, where all of their goals are, something to the effect of decrease anger, right? Mm-hmm. But that is not very specific, it's not very measurable. And I know that it doesn't always have to be measurable, but all of them are very generic. So I just want to know, like, how can we determine whether we're actually working towards the identified goals, and how do we know we're actually going to achieve those goals if all of them are extremely generic?
I
We're going to
concur
talk
that.
more. We're going to talk more about what actually needs to go into a treatment plan. When you get a treatment plan initially that you did not do yourself, it is ultimately your responsibility to modify that and work with the client to make it more specific.
Okay.
The assessor is not the one who's going to be working with the client. So they do make very general, vague treatment plans. But as the clinician who takes the case, it is our responsibility to look at that treatment plan. And as we get to know the client better, to modify it and make it more specific, more measurable. And we'll talk about SMART goals in a few moments.
Okay.
Really
Okay.
good
I'm
question.
jumping the gun a little bit. Okay.
It's
Nah,
okay.
Nicole, I was with you. It's okay.
It's okay. I know you guys are going to have questions, but please trust that I will get into more detail as we go. So starting with clinical assessments, we're going to get into more detail about assessments first, okay? So the assessment, the whole goal of the assessment, like I said, is to provide that overview of the client. Now, no one can spend 1 to 2 hours with someone and get to know everything about them. So the point of the assessment is not to play detective and find out every little thing about someone in their life. We would need way more time. And honestly, that wouldn't serve much of a clinical purpose. Our real goal with the assessment is finding out, where are you right now? How did you get there? And how can we help? So if we find out the right information at assessment, we have that solid foundation that's going to justify they need the service, and it's going to inform us, what do we need to do to help them meet their goals? The biggest thing is collecting enough information to justify a diagnosis or the diagnoses, to build treatment goals, and to justify the service recommendations. The assessment covers information in a lot of areas. The biggest chunk is going to be the presenting issues. So in order to make a diagnosis and justify whatever diagnosis or diagnoses we are going to make, we have to know what's going on. What areas are you struggling in? What symptoms and behaviors are present? How long have they been happening? How frequently do they happen? And how intense are they? So the clinical assessment starts with this presenting issues section, and even the presenting issues are broken down with different categories that prompt you to know what questions to ask. There's going to be sections where you ask about depressive symptoms, symptoms of anxiety, symptoms of trauma, symptoms related to psychosis, etc. Anytime you're going through presenting issues, the most important things to remember are that frequency, intensity, and duration. When did it start, right? That tells me how long it's been going on. How often is it happening? And what is it like when it happens? What's the intensity? So someone might say, I feel sad a lot. Right? When did you first start noticing that you were feeling really sad? How many days a week do you feel really sad? How long in the day? Is it, about an hour a day? Or is it, I feel sad all day, 4 to 5 days a week? And then when you tell me you feel sad, what is that like for you? Are you feeling so sad that you can't get up out of bed? Are you feeling so sad that you're crying? Is your sadness leading to anger? So you are hitting things, throwing things, lashing out at people. All of those pieces are going to help us clearly and specifically identify what the client needs to work on, what we need to do for the client to help them, and then what their diagnosis or diagnoses may be. The other areas of the clinical assessment are to do with the client's history. So we want to know their behavioral health history. Have you been in any type of mental health services before? Have you previously had mental health diagnoses? Have you been on medications before? We want their medical history because physical and mental health tie together, of course. We want to know their developmental history because sometimes that can give us insight into whether or not these struggles might have started within childhood. Educational and vocational history, their living situation, family history, relationship history, what's going on now with your family, what has it been like in the past, their legal history, their drug and alcohol history, which is very important because that could be related to what's going on as well. And then their resources and their strengths. It is a small part of the assessment in what it looks like. However, this is really important because we want to know what the client has going for them because they do have something going for them. Usually they have lots of things going for them. They have natural strengths. We need to know about that because that's going to help us help them, and that's going to help them help themselves. Their mental status profile, we want to know how they're currently functioning while they're with us in the assessment. And then we do make a clinical diagnosis. We write a clinical summary that kind of gives an overview of, okay, this is what they said they're struggling with. This is diagnosis, and this is what we're going to do about it. And then that ties into the recommendations. When we do a clinical assessment, the ultimate goal is to decide what needs to happen next. What does this client need? Do they need outpatient counseling? Do they need medication management? Do they need case management? That's going to be the clinical recommendation that we make based off of all the information gathered. Before we move on, any questions about the clinical assessment? Not the technical, how do I do it incredible questions, but just on a wider scale, I suppose. Okay. One thing to keep in mind though when you do a clinical assessment is there is no set order that you need to do things in. So when you're doing an assessment, it's set up in this order that's listed on this slide. But as you get used to doing them, you might find that jumping into presenting issues right off the bat is not sometimes helpful or appropriate for the client. Sometimes talking about more historical, even more kind of impersonal things such as medical history, can help the client feel more comfortable with you before you get into, okay, what's going on right now? What brought you here? Because that stuff can be a little bit harder to talk about. So now we'll talk about treatment plans. You guys have been dying to talk about treatment plans. I can see it on your faces. So when we develop treatment plans, the ultimate goal is to develop what we call SMART goals. They are specific, measurable, achievable, relevant, and time-bound. Let me back up though. So a treatment plan is going to be comprised of goals, objectives, and interventions. Goals are the big picture, overarching idea of what the client came to you to get help with. Susie says, I really want to feel less unhappy. That is a good example of that big overarching goal. But our objectives are meant to bring things in down to a more specific, measurable, achievable, relevant, time-bound place so that we can know specifically what we need to do. And so we can have a way to track whether or not progress is being made or things are going well. If our objectives are specific and measurable, then our interventions can be more specific and measurable as well. So if Susie says, I want to be happier, right? We have to think about, well, what would get us there? What steps could we take little by little, one by one, to get you to a place where you do feel less unhappy or less depressed? When we start with SMART goals and we do our treatment notes and we do our treatment plan reviews, we'll find it a lot easier to report on progress because we'll know what we're measuring. We'll know what we're evaluating. So let's look at this concept of SMART goals, right? So specific. When you're setting a goal about what someone wants to be accomplished, the more specific you are, the more realistic you can be about that goal. So if Susie says, well, I just want to be happier. If you and I were meeting once a week, once every 2 weeks, and all we knew is that we're just trying to get you to be happier, it'd be really hard for me to determine what we should be doing. It's really vague, and happier, well, that doesn't even look the same for everyone. Happier for me might be that I spend less time worrying about something. And happier for Susan or Susie, whatever I called her, might be that she enjoys more time with people. Could be very different. So the more specific we get, the more I understand what we need to be doing together. So Ashley says, I want to decrease my depressive symptoms. And that's a great place to start. That's a great big overarching goal. That's not a very good objective because it's not specific. I can't measure it. I don't even know how achievable that feels, right? I just want to be less depressed. And it's not time bound either. So if I want it to be more specific, Ashley can work on maybe some coping skills that would in time contribute to the decrease in depressive symptoms, right? That is a much more specific objective related to the overarching goal of decreasing depressive symptoms.
I have a question.
Yes, ma'am.
All right. When we're talking about SMART goals, you're talking about the entire treatment plan being SMART, not just the goal being SMART, because I hear I want to release or reduce depressive symptoms, but it's still not measurable, nor is it time bound. But when we get into the objective, it's okay because that's going to address the measurable and time bound part.
Right on.
Okay. Thank you. I'm understanding.
Right on. Yeah. So when we look at the breakdown of a treatment plan, like I said, the thing that's actually called the goal on the treatment plan that we do in the system, right? That doesn't have to be each and every one of these things. It doesn't have to be super specific, measurable, achievable, relevant, time bound, because our objectives are going to be. Our objectives are where we get into this SMART idea. But by doing that, it does make the entire treatment plan a SMART treatment plan. So I try and make my objective very specific, right? But we can be specific in that we're going to work on coping skills or even work on, let's say, mindfulness techniques. That's a specific type of coping skill. But if I just leave it there It's like, okay, when, how long is it going to take? What's the point? Do I really feel like I'm going to get anything out of it? So we go into making it measurable, right? How am I going to know whether or not this is a goal that we met? If
So
I
at
just
the end of the
say,
6 sessions or end of 12 weeks or by the next ISP review.
right. So this is where we get into some sort of measurement. Ashley will learn and implement 2 mindfulness techniques within a certain period of time. But the measure is how much or how often, right? Or if we want to see a decrease in something, how would we know that it's been decreased? If somebody wants to decrease their incidence of crying, right? And when I'm struggling with depression, I might just find myself crying. If I want that to stop ultimately, well, we look at, let's try and get that frequency down. But down from what to what, right? If it was happening 5 days a week, maybe our objective here is that we get it down to 4 or 3 days a week, right? Which goes into the achievable part of it. When we make goals for ourselves in any area of life, if we do not feel like they are achievable, we are way less likely to make progress towards them. If my house is an absolute disaster and I just go, well, I want it to be great. I want it to look great. I want it to be clean. I want it to, that's great that I want that. But if I don't have any steps in between, it's a disaster and I want it to be, a masterpiece, I'm not going to know how to get there. My goals need to be very specific and I need to believe they're achievable. So if my house is an absolute wreck and I look around, I can start with, I am going to vacuum the living room rug. And I can do that. I'm going to vacuum the living room rug by 4 p.m. on, Tuesday, 6/7. I have a vacuum cleaner. I have arms. I have a plug. And I have time until tomorrow at 4. I believe I can do that. Does that make sense? If it doesn't feel achievable to the client, then they're way less likely to actually achieve it. So Ashley may feel like decreasing her depression, that's just this big, wonderful idea, but how the heck am I going to do that? Ashley could have been depressed for years at this point, and she's thinking, sure, that would be wonderful. It is ultimately what I want, but if I knew how to make that happen, I wouldn't be here. I need to feel like there are achievable steps to get there. An achievable step might feel like learning one new coping skill over the next month. An achievable goal might be, I don't think I could get out of bed every single morning this week, but I can go for maybe by next month, maybe in the next 3 months, there's 2 mornings a week where I get out of bed by a certain time. If they don't feel achievable, they're less likely to be achieved. That's why that's very important. It's equally as important that they're relevant to the client and to that goal that they reported they had. If Susie's telling me I want to be happier, but then she's like, oh, I want to work on, can I have an objective about, that's kind of a hard example. Everything could go into being happier. But let's say Susie's objective is, or her goal, reported goal is social skills, right? I want to increase my my social engagements, improve my social circle, improve social support, something like that. And then she says, oh, let's make my objective about actually trauma processing. Well, that's a completely different area, arguably. We want the objectives to be relevant to the goals. That doesn't mean that Susie might not need to do trauma processing and social skills, but we need to put things in the right areas. We need to have the focus on the right things. And if it's not relevant to the actual client, then they're really not going to work towards it. And that's where making sure our treatment plans are person-centered becomes very, very, very important. I don't determine what someone else wants to work on, right? So if I am creating treatment plans, treatment goals for another person, it may not end up being relevant to them. Now, look, we're clinicians. We're going to see a diagnosis. We're going to read about the, reported issues, and we're going to have ideas of what might need to be improved, right? When someone tells me, well, I just am having flashbacks all the time and I don't know how to bring myself out of them and it freaks me out. I'm immediately thinking of things that might help them, right? Like, oh, we need to learn grounding, and my head's just spinning with all the ideas that these are the things we need to work on. But if the client says, oh, that's not what I want to work on, I'm not interested in that, then it doesn't matter. We need to make sure that the goals we create are relevant to the client and relevant to what they report is going on.
Okay, so question. FYI, I'm always full of questions. So the client does not want to work on what maybe your train of thought is going, but what they want to work on does not relate to the assessment or the ISP.
So give me an example of that.
Okay. So the client, in the assessment, the client is, like you said, okay, showing PTSD. That's the diagnosis that is given. ISP is kind of set up, and we're starting to work on goals, and we want to reduce clinician brain. We want to reduce how often this person is having flashbacks, and they say, no, that's not what I want to work on. I want to work on being able to talk to my mom. How do we relate that back to the assessment and the ISP?
The first thing is we might need to actually gather more information about what's going on with the mom. And maybe they didn't tell us anything in the assessment.
Okay.
But it's probably time to have a conversation. Because if that's something that's on their mind heavy enough to want to put a goal in the ISP about it, then there might be a lot going on there. That might relate to the trauma. I don't know, because I haven't learned yet. So the first thing would be digging a little bit deeper into, I wonder where that's coming from, right? And we might find that it is actually relevant. It is actually tied to the stuff they already told me.
Okay.
On the other end of that, sometimes they will come up with objectives or goals that don't sound necessarily like they're connected. And we might just need to help them a little bit with language, or even just helping them realize a little bit clearer what we are here for versus what other services are here for. Sometimes with outpatient, especially, clients will bring up something like, I want to change my housing situation. Not that that's completely unrelated to outpatient, because it's not, but I'm not going to be locating, sharing, linking you to housing resources necessarily if you have a case manager. So I might need to collaborate with case management and make sure that that's something they're working on. But I could look at well, what has led to housing difficulties and what might continue to impede your ability to obtain and maintain stable housing, like social skills, that can be a big part of it, people who have difficulty getting along with others. Sometimes it's actually like something like depressive symptoms, and I don't maintain my housing because I don't even have the motivation to get out of bed and to clean, and I haven't had the motivation to go out and get a job and make money, and so my financial situation leads me to housing difficulties. So
Okay.
sometimes it's digging a little deeper. That might not sound super relevant to begin with, but then you might find, oh, well, there's a lot of actually clinical pieces to this bigger picture issue.
So
And that's
dig.
why that's why we get more specific.
Okay.
Yeah.
Dig and golden thread it away. Got it.
Dig and go and thread it away. And amendments can be made to assessments.
Okay.
It's not unusual for a client to not tell everything in an assessment because it's overwhelming. And especially when it comes to things like trauma, sometimes people just they're not comfortable enough to open right up. So a few sessions in, they might say, oh, I really want to talk about my mom. And you're like, oh, your mom, huh? What's going on with that? And then they just start spilling beans about, oh, well, my mom abused me for 10 straight years, but nothing on the assessment talks about that, right? And their diagnosis had nothing to do with trauma or PTSD. But then you basically are learning like, oh, this client has PTSD. Wow. Amendments can be made because we want to make sure their diagnoses are relevant, and diagnoses can be changed as needed. So if that were to happen, then of course we would want to be updating treatment goals as well. So good questions, good questions. I know it's a lot and it can feel very complicated. But we learn as we go. And there are situations that come up where we won't always have the answers. And that's why we have managers and supervisors who, from what I know, are all pretty great. So, not to toot my own horn, I'm talking about the other ones. So, they need to be achievable, specific, measurable, relevant, and then time bound. So, I want to learn new coping skills. Great. That's great. Just within the next year, several years, lifetime. If they're not time bound, then one, again, it's kind of hard to see progress, but two, I'm more motivated when something is time bound. I'm going to vacuum the house. I am. It's going to happen. We're going to vacuum the house. Okay, when? When are you going to vacuum the house? I'm going to vacuum the house by Wednesday. Oh, okay, that feels more real. That gives me a little bit of fire. Like I got to do it. I got to make a plan for getting it done if I got to do it by Wednesday. Our goal from the beginning, our work with a client from the beginning, our goal is discharge. Not because we don't want to talk to them and we just got to get you out the door, but because my goal is for them to look at me and say, I don't need you. I got this. All of those goals I said I had, I met them. We're doing a disservice to somebody if we're not putting any sort of timeline on things, because well, I guess we'll just sit around and talk to each other once a week or a couple times a month indefinitely. And then I won't ever feel any better or feel like I can do things on my own. And all you did was basically enable me to become dependent on you. It's not what we do, right? Our goal is to help themselves by identifying what they want to work on, what they need to do to get there, and putting timelines on things. If my goal is to vacuum the house by Wednesday, worst case scenario is I don't vacuum the house by Wednesday. Now, you might be thinking, okay, so the client says, I want to learn and implement 2 mindfulness techniques, to help with my depressive symptoms by within the next, let's say, 90 days. 90 days goes by, you're doing a treatment plan review. And the truth is, we have talked about loads of mindfulness techniques. We've practiced them together. But, Ashley she doesn't seem to implement them anytime outside of session. She's just not really doing it, right? Worst case scenario is, the truth is, we set this goal, we set the measurement, we set the time, and they didn't meet the goal. That gives us an idea of what we need to maybe do differently, though. Because then the question is, well, what kept Ashley from implementing these things that we learned, we practiced together in session? Why in 90 days did this not help? Is it because that's just not the right way to go? Maybe mindfulness is not her thing. Is it because she's lacking the social support outside of sessions to have people help prompt her when the difficulties arise and I'm not there for her? But that can inform the changes in the treatment plan that might need to happen over time. Because if our goal was something that ends up not being achievable right now, then we need to change it. And we might need to get more specific or get more relevant. Maybe coping skills wasn't the thing we needed to start with. Maybe we needed to start with just having somebody, social support, finding some way to get more social support. Maybe even just working on some social skills so that the people that around Ashley are able to better understand what she needs and better help her. I'm going to move on.
I'm sorry.
Yeah, go for it.
I mean, do we have to wait for 90 days to realize that something's not working?
No, you do not have to wait for 90 days. When it comes to time bound, you can choose what you want for, your time frames. The only thing I will say is, if you're making objectives meant to be met in too short of a time frame, then you want to think about, realistically, how often am I going to be reviewing this treatment plan? Realistically, it is probably going to be happening around every 90 days.
Okay.
If I say by next month, then I need to be planning to do a treatment review next month, even though it's not going to be due next month. And that sounds great, but is it necessarily realistic? Just as we want our clients to have realistic goals, we want to have realistic goals for ourselves.
Mm-hmm.
Again, you can review a treatment plan at any time. You can change goals, update goals at any time. But realistically, we're not going to be doing treatment reviews every couple of weeks, every month. So try and balance that. A lot of these questions are going to be more of a case-by-case thing as well. So this is where you're learning this big picture general information right now. But when you're actually having cases and you're developing treatment plans person to person, the learning will be by going to your supervisor and saying, okay, here's what I'm thinking. Here's what they're telling me. What would this look like? So
Okay.
I hope you don't feel too overwhelmed right now, because this is all just kind of more general information.
Okay.
But yeah, treatment plans, they sound very complicated, but ultimately, if we have good objectives and then clear interventions. So intervention should also be smart, right? Teach client mindfulness skills. Okay. Do you know mindfulness skills? Which ones? What do they look like? Like mindfulness, like, okay. But if you yourself don't even know like what that means and what those are going to be, How are you actually going to teach them to the client? So get more specific instead of just coping skills. Which coping skills? Do you have any idea of what coping skills might actually be relevant and useful to the client and what they said they need to work on? Just something to think about when you talk about your intervention. No, your interventions don't have to spell out, this is what I'm going to do in the next 6 sessions. That's no. But if you can get more specific, it's a great time to. Don't sell yourself short. I know you guys have great clinical knowledge. So if you're working on coping skills, don't be afraid to type in that intervention section, what coping skills you actually plan to bring to the client and help them learn. All right, I'm going to move on. Progress notes. Progress notes are going to involve, like I said, an overview of what you're doing with the client each time you meet with them. So if there's new or really pertinent information that the client provides, if there's notable significant changes in their mental status from session to session, what goals and objectives we addressed, because in some way, shape, or form, we should be addressing a goal or objective. Interventions that we provided, right? What did we actually do? And then how did the client respond to what we did? So a great example would be the client comes to me and they're talking about how difficult the past couple of weeks have been. And I'm looking at their treatment plan and I'm noticing one of our goals was to learn grounding techniques, right? Learn and implement grounding techniques, because the client gets flashbacks and they get triggered easily and they have a really hard time pulling themselves out of that. So I teach them how to use the 5 senses to ground themselves to the present moment. I need to say in my note that I did that, right? That's my clinical intervention. That's what I brought to the table. But I also need to note, how did the client engage and respond? Was Sam like, oh, that's stupid, that ain't gonna work for me? Was Sam like, yeah, sure, okay, yeah, I'll practice, I feel things, okay, great, and kind of dismissive and not super engaged? Was Sam highly engaged? Did Sam even report that, I learned this before and I never used it? And did we talk about what kept him from using it last time? I want to know how the client participated and how they responded to what I brought to the table. And over time, the note should reflect the progress that is or is not happening towards those goals. Sam comes back next week and he says, I tried that grounding. I tried it. The first couple of times it did not help. And I thought, this is just utter nonsense. But you know what? Yesterday I was getting a flashback and I tried it again. And my mind really did feel like it was kind of coming back into the present moment. I did feel a little safer. That's progress right there. We need to note that progress. Now, progress notes are not books. They're not novels. They're not word for word, just this is every little thing the client said, this is every little thing the client did. Progress notes can look quite short as long as they are specific and they're providing the correct information. Bob's going to come to session and he's going to tell us, last week I was at work and this person came up to me and they started yelling at me because we were out of cheese and I didn't know what to do because I'm not the one who orders the cheese and it's not my fault we were out of cheese, but they were just, I'm not going to type in all that in my note. Okay. Bob said, end quote. Last week he was at work and she's in something. No, 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 no. No, no, no. But if him sharing that prompted me to go, oh, well, we, we do have a goal in your treatment plan about managing, difficult social situations and learning coping skills. Let's talk about some, I don't know, maybe conflict resolution, right? What do we do in this scenario? How do you regulate your triggered emotions so that you can engage in healthy conflict resolution? Well, I'm going to put in my note that we discussed and learned conflict resolution, but I don't have to put every little detail about what happened with Bob at work last week. Before I move on, any questions about progress notes? Okay.
No.
Treatment plan reviews. So we're going to have these treatment plan reviews every 6 sessions or 90 days, whichever comes first. And this is where we have a good opportunity to take a snapshot of what we've done so far. Now, our progress is being shown in treatment notes, but the treatment plan review is going to give a more specific overview of what has happened so far, what has not happened so far, how's the client doing right now, and then what do we need to keep doing or do different moving forward. So first, we're going to look at, okay, how is Susie functioning right now? And how is that maybe different or the same as she was functioning 90 days ago? Susie continues to, right? Susie continues to report a high level of depressive symptoms occurring, 4 of 7 days a week, or Susie reports a decrease in depressive symptoms from 4 days a week to 3 days a week. How is she currently functioning? How's it different or the same or worse? Let's be real. Sometimes things can get worse before they get better. Then we're going to give a snapshot of the progress or lack of progress. Each objective. So if I have an objective about social skills, coping skills, and my mind does not work. So coming up with examples, not my strong suit. So let's just start there. I need to talk about the progress towards each objective, not just like, well, Susie's learned some coping skills. Great, let's move on. Okay, Susie has learned deep breathing and has been able to implement deep breathing techniques 4 times in the past month to decrease feelings of panic. That's a really good specific way to notate progress. But if she had a goal down there on the treatment plan about increasing conflict resolution skills, I need to report on that too. Susie has engaged in learning conflict resolution skills through role play and discussion in sessions. However, Susie reports feeling ill-equipped to implement the skills in real-life scenarios and continues to have, daily or weekly conflicts with peers, coworkers, family members, whatever it is. The treatment plan review isn't just, okay, let's judge how the client's done so far. It's a really good opportunity to evaluate, how have I done so far? Am I actually helping? And do we need to keep doing more of the same thing, or do we need to change things up? Are the client's needs still the same? Clients meet goals. If their goal was to learn 2 mindfulness techniques and implement them independently, and they've done that, then that's not their goal anymore. They don't need to keep working on that, right? Or sometimes, look, we come in and we think, this is what I really, really want. I want this. I really want this. And then 90 days go by and you're like, no, I don't actually want that. Or my life circumstances have changed and that's just not the priority anymore. Or I thought I wanted to process my trauma, but it turns out I'm not ready. I'm not ready, but I might be ready to do some other things. So it serves as a good opportunity to reevaluate what the client actually needs. It should include both our perspective as the clinician and the client's perspective. Please don't do treatment plan reviews and just say, well, this is what I see. And not ask the client, not talk to the client about what has it been like for you? What's your perspective? Do you feel like you've made progress? How would you evaluate your needs, right? But also don't just do a treatment plan review and say, okay, Susie, here's the goal. Did you meet it? Next. Here's this goal. Did you meet it? Next. It should include both perspectives. Okay, we are going to move on. Collaborative documentation. So when we do progress notes, the biggest thing that's going to help you out in terms of time management and stress management and really doing good documentation is collaborative documentation. Collaborative documentation meaning clinicians and clients collaborate, yes, they work together to do the documentation of the assessment, the treatment plan, the progress notes together, right? This makes a lot of sense for assessments. This makes a ton of sense for treatment plans. But you know where we typically fail is with progress notes. We have a session, we say, bye-bye, client, and then we do that progress note. We don't include them in that process. But if we do include them in the process, it provides the client with the opportunity to provide their input and their perspective, and for us to get feedback on how services are going. It allows the clients and the clinicians to have clarity on the important issues, and it improves the client's sense of involvement in services. If I come to counseling every week and I just kind of like have this vague sense of like, oh, my therapist writes notes about me when I leave, it's a lot different from, oh, we write the note together. I know what she's putting in it because she's asking me questions and she's typing in front of me. Collaborative documentation saves us time because we do the notes while we're in the session with the client. It can offer us an opportunity to better help the client. Like I said, improve the client's sense of engagement and sense of, what's the word? Like responsibility in their role in sessions. It supports person-centered services because their direct feedback is going into notes. Their language can go into notes. It helps us focus our clinical work, improve our work-life balance, and improve compliance with documentation timelines. Because when I do my notes at the end of the session with the client, before we even end the session, I'm not going to not get that note done in my time frame because it's going to be done right then and there. It's awesome. I'm just checking my notes because I don't want to skip things. Okay. So implementing collaborative documentation. The most important part of doing collaborative documentation is making sure the client understands what that is and what that means for them. So with the assessment, it's pretty simple. When we gather information from the client, we can check in with the client and ask for clarification on things. So far, this is what I've heard, right? So far, you've told me that 7 months ago, you began experiencing depressive symptoms. You told me those depressive symptoms were crying spells daily, difficulty sleeping, about 3 or 4 hours a night is the most you're getting, loss of appetite. You said only one meal a day is what you're eating, and just a total lack of motivation. Does this sound accurate to you? Does that sound correct? Is there anything I'm missing? That is the collaboration that can happen between you and the person across from you that's going to increase their sense of engagement and ownership of the service. You review areas of need and problems, and you document the client's opinion of what they need, right? When the client says, I just really, yeah, it turns out I really I need more friends. Like I just don't, my family's all moved away and I live here and I just kind of realized as we're talking that I don't even I don't even have any good friends to rely on. You're listening, you're documenting what they're saying. You can use their language as well. I need more friends, right? When we're doing a treatment plan and someone says, I just want to be happy, you can quote that on the treatment plan. Progress notes. If you do collaborative documentation, it's not just, oh, well, I get my notes done at the end of sessions so that I don't have anything else to do at the end of the day. You're getting more buy-in from the client by involving them in that process of writing a note. But it all starts from the beginning, explaining to them that this is an important process of what we do together. Emphasize the value of it to the client. I'm gonna make sure I always get your perspective on how our session went. I'm gonna make sure that when I write our notes, that your opinion and your sense of progress is included, right? I'm gonna make sure that you know what I'm writing about you, because it feels a lot better to know and not feel like, oh, she writes secret things about me when we hang up, when we end Zoom, right? And you can set it as a routine, right? You start from the beginning. So our sessions, around the 45-minute mark, we're always going to have been winding down so that we can start writing our note together. And this is what it's going to look like. I'm going to ask you what you remember of what we covered today. I'm going to ask you what you got out of our session today, what you liked about it, what you didn't like about it. And then I'm going to jot down a little overview of what we did and talk about what we want to do next time or what we need to continue working on. And it helps wind down the session naturally instead of, okay, we really have to go. I have a client coming in a minute. Like, we really have to go. Oh, I'm sorry. That's not really the best, is it? So when we're doing collaborative documentation with the treatment plan, we can start with discussing the previously identified problems, right? So this is what you told me you were struggling with a few months ago. Is that still what you're struggling with? Like, is that still what you want to work on, right? When we're trying to make treatment goals and we want to be more specific, there's lots of questions we can ask. They say, I want to feel happier. What do you think would have to change in order for you to feel happier? Right? In the next month, what's one thing that you think you could learn that would improve this area you're telling me you're struggling in? What do you want the outcome to be as we work on this, right? If they say, I want to work on social skills, what do you want the outcome to be? Are you thinking that would look like I have 25 new friends by the end of the year? Or are you thinking I'd be thrilled if I had one reliable friend by the end of the year? That's really, really important for us to know. Like, I shouldn't just be assuming what I think they want, right? The treatment plan objectives, we can think of them as milestones, not necessarily like things the client has to do. So, I'm going to feel more competent in my coping skills by this point, not necessarily like I'm going to have to change everything about myself. I'm going to have to, you know, have 4 people's phone numbers by December. But maybe I am going to feel more confident in my ability to connect with people, to meet new people, to talk to new people. And we talked about measurable things, right? Things being measurable. It's going to make me feel, 1, more able to do it, 2, more motivated to do it, and 3, it's going to give me a clear sense of whether or not I met it, because it's measurable. I can literally see whether or not I met it or not. Checking the time. Okay. So that's the last thing we need to do. So if it would let me go back, it won't let me go back. Don't ask why. Go back here. Any questions so far? Oh, great. We're at the beginning again. Any questions so far?
No. Oh, I do have a quick question. So if we feel like if we feel like we've already kind of like identified some goals with clients that aren't necessarily on the treatment plan, should we, speak to our direct supervisors and then go in and change those goals on the ISP?
Absolutely. So the treatment plan is what we would think of as a living document. It's not okay, I did it and it's going to stay this way. At any point in time, the treatment plan can and should be changed. A really good example is, so a lot of times when a client is driven to services, they're in some sort of crisis, right? We as humans love to sit around and say, we're fine, I'm fine, until things are just so bad that it's like, crap, I am really not fine. So they come in the assessment, their head is filled with whatever the crisis at hand is, right? I am about to lose my house. My wife is leaving me. My trauma has just gotten real heavy lately. So I can't even, I'm afraid to leave the house, or I can't drive anymore. Whatever the thing at hand is, it feels so heavy and so important, right? That's going to be where their mind is focused. So that's probably going to be what our treatment plan ends up initially being wrapped around. But give it a little bit of time, things can significantly change. When I first came to services, I was just so upset because my wife had walked out on me, but she came back a couple weeks later, and you've been helping us work towards those issues. But to be real, I realized what is underneath all of that is this unresolved trauma, because she left because I was having these awful, behavioral reactions to my triggers. So it turns out I don't really need to work on my wife coming back, or, I really need to work on my trauma. Oh, okay, that's great. We learn these things as we go through services, but I need to change my treatment plan. I need to adjust what our actual goals and objectives are. We can change it anytime, but yes, it does have to be done in an official way. We can't just go in and mess with people's treatment plans all willy-nilly, because essentially it is their treatment plan. So they always need to have ownership of it by signing and saying, yes, these are my goals. And the only way they can do that is if we do it through an official service and our lovely, credible system. Any other questions? Any questions about doing notes collaboratively? Do any of you have thoughts of what would stop you from doing that, or what would not feel comfortable about doing that?
With like another clinician, writing style. I'm finding it hard now as my notes get reviewed. Everyone has a particular writing style when they do their notes. They still cover the same core things, but it's like, oh, we'll put this here and put this here, and trying to find that happy medium where I hear you and I understand that that is your developed style, and I am trying to maybe develop my own, as well as make sure I hit the points that, my supervisor is telling me that to make sure I'm hit. Those are the reservations I have.
Okay. So to clarify, when we do collaborative documentation, the collaboration is between me and the client. So
Okay.
the idea is that I'm actually writing my note in the session with the client. So back in the days of seeing clients face to face, which some of us are still doing, some of us mostly Zoom, my computer would go into the session with me. And at the end of the session, before the end of the session, to give us time, right, I would pull up the note and we would start typing out together. So what can you give me, a sense of what we talked about today, what you learned today, what you liked about today, what you didn't like about today, what you would want to work on next time, and actually typing the note out while you are with the client.
It's like such a hard concept for my brain to compute. I'm being totally honest, because whether I'm in person or in a Zoom, I'm trying to focus on that person. I'm like, I can do multiple things at once, but not when it comes to writing a note. I have to either do one or the other. I struggle to do both. So in our hour sessions, with those last 15 minutes, we'll sit and we'll do the note together.
Yeah.
I'll
See,
try it, but I have so many reservations about how much my brain is going to actually stay on track, if I'm being completely honest.
absolutely. So those are the things that I hear all the time, right? I can't multitask, I can't talk and type at the same time. And I relate. I also, well, yeah, I can barely do one thing at one time. But this is where we, knowing ourselves and what works best for us, we have some flexibility in how we do this.
Mm-hmm.
So when I say typing the note with the client, that doesn't have to necessarily mean that I word for word type out exactly as I want it to look, sign and submit before the client leaves. But the collaborative process is that conversation that I'm having with them. When I'm asking them, what's one thing you got out of today's session? Or what did you think about, we talked a lot about this grounding stuff. What did you really think about it? Did you find it helpful? Do you think you're going to be able to try it? And then typing out their response. I can go back, I can make it look more clinical, professional, or whatever. I don't have to hit the sign and submit. But that important piece of collaboration is having that conversation and letting them know what you're putting in these treatment notes. That ownership piece is really, really important. These are my sessions. This is my time. I have ownership of what we do together. And I know that because my clinician is letting me know that my feedback is important. And the most important part of doing things collaboratively, doing documentation collaboratively, is eliciting feedback. There's something on the ISP summary review form that says, basically, how does the client feel like client services have gone so far? So every 90 days, I'm going to ask them, hey, how have services been? That should be happening every session, essentially. It should be a habit to elicit that feedback from the client. Because if I go to the doctor and I'm seeing the same doctor for years and years, and suddenly they're like, hey, am I a good doctor? And be like, oh, yeah, I mean, of course, sure. But if I go to a new doctor and the very first time we meet, we talk, and she says to me, so how do you feel like today went? Do you feel like your needs were clearly heard? Do you feel like I fully understood when I'm gonna summarize what you just said. Does that sound accurate? Well, okay, sure. We just met. Okay, you're asking for my feedback. I'd love to give it to you. And if that's the habit, right? Every time I go, she asks, okay, did you get what you need from me? Do you feel like I understood you? Is there anything you would want me to do different next time? Is there any kind of treatment that you wanted to explore that I haven't brought up, but you're like, hey, I kind of was thinking? We just become comfortable. This is what we do. We just talk freely like this with each other. And I can make sure that I'm getting what I want, and she can make sure that she's providing me with what I need. Win, 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 win.
I think, well, not I think, I did try it once with the client and it did not go that well. I think only because I think it wouldn't go so well if a client is like actively in some sort of episode, like a manic episode. And I think that that client may have been in a manic episode, or something to a similar effect, just because when I was, doing it and we had discussed it, she had like stopped talking and I was like, are you still with me? And she was like, yeah, but I heard you doing something else. So, I mean, I just stopped talking because I wanted you to listen. And I was like, yeah, but remember, I'm just typing up the things that we're talking about, typing down the notes like we had discussed. And she was like, oh, yeah, okay. And then just continued to go. Right. But it was much more like it was a lot of signs that showed me that told me she was in a manic episode at the time. But I think that would be one of the main concerns for me as far as the collaborative documentation, just because like they might literally forget that you have discussed it, even if you do it, throughout the session, or if you do it at the end of the session, and then they're like, why are you asking me this again? You know what I mean? So I think that would be my only concern.
So every client is different. So our approach should not be so standardized that
Right.
this is only going to work for some people, right?
Mm-hmm.
Even session by session, people can be very different.
Mm-hmm.
This doesn't mean, okay, I have to do it this way. I have to ask the same questions every time, and I have to only type what they tell me by any means. There can be some clients will tell you, look, I don't care. I don't care what you put in your note. Honestly, I'm so stressed right now. I don't even want to think about it.
Mm-hmm.
We're still learning from that, though. You still learn something when you say, so what do you feel like went well today? And they're like, oh, I don't even remember what we talked about. And don't ask me. I don't know. I'm just here.
Mm-hmm.
I just learned something from that right then and there. It's important regardless of how it goes, right? It's not meant to be this, okay, here's this 5-step process. It works perfectly for every person, but it still engages them and it still shows them that your feedback is very, very important, that this is your service. You get
Mm-hmm.
to make decisions about it. It's okay if a client's like, I don't know. Or if a client's like, I hate when you ask me that.
Mm-hmm.
That's feedback, though. I hate when you ask me that is them expressing their needs and their opinions and their desires. Okay, then we can agree that I won't ask you that. Is there a different way we could discuss this, though? Is there something you'd like me to ask instead? A lot of it is learning with the client, but if you make a habit of it from the beginning, you find what works for that particular person, and then you go with it. Regardless of whether or not it's the type of person who's going to let me sit there and type up the note right in front of them, or the type of person who I'm just going to need this in the session a few minutes early with so I can finish typing up the note when they're not in the room with me anymore. these are the little nuances that you'll learn over time.
Mm-hmm.
But that's a good question, a good point.
Okay.
Anybody else? Questions, concerns, questions about anything that we talked about?
Yeah, I have a question about the goal and versus the objective. I know that the goal has to be you know, specific, and the objective has to be more detailed. Maybe the goal has to be just the baseline, kind of vague, and the objective has to be more detailed. But what does that actually look like?
Mhm.
If we have a goal for a person trying to have more happy days than sad days, would the goal look like the client will have more happy days, or what does that look like? Like, can you give me an example?
Yeah, so if someone's goal, if they just say, my major goal for treatment is to just have less sad days, or to just feel happier, or decrease my depression, whatever it is, that's fine for a goal. But when it comes to objectives, we're finding those specific kind of baby steps that could help us ultimately get to that place. So my objective isn't going to be that, okay, I just have less sad days now. What would make a day less sad? What would equip you to better handle those feelings of sadness? Those are the questions that if we ask, we get more specific answers. Well, my day would feel less crappy if I was able to get out of bed in the morning. Awesome. That is a great objective. Is that we're going to increase the number of mornings that you are able to get out of bed. But we might need to get more specific than that, though, because now that I think about it, well, what would help you get out of bed? What's the reason that you're having trouble getting out of bed? It could be a motivation thing. It could be that I'm not going to bed early enough to get any sleep, and that's why I can't get out of bed. It could be more of a sleep thing. There could be physical things going on. One of our goals could be that you need to work on maintaining your physical health better, right? We might need to be making a goal to like get out and have a few walks during the week, or maybe your eating is part of why you're feeling sad all the time. You're not even eating very much, and maybe we need to have goals about, the more we talk about it, the more specific we can get, and the more we can break it down. Because even something we might think is pretty broken down, right? We might find, no, there's still a lot underneath that. So a lot of that has to happen through the conversation with the client. You say that you want to get out of bed by 8 a.m. in the mornings. What does it feel like? You wake up and you just can't bring yourself to do it. What does it feel like in that moment? What are your thoughts in that moment? What is happening? When did this start? Like, what do you think would have to change in order for you to go, I'm going to get up right now? And that's going to inform those more specific objectives.
Okay.
Any other questions? Okay, so the last piece of this is a little homework assignment. So you're going to get emailed a case scenario, or a little clinical summary, essentially. And you're going to create a treatment plan based on the provided information. So all I'm asking is that you create at least 2 goals with the objectives and interventions that you would want under that goal. Remember to use the SMART goal, ensuring that your objectives are specific, measurable, achievable, relevant and time bound. And then you will email that back to, well, actually, you will give that to your manager and review it in your next supervision with them.